Welcome everyone, and thank you for joining us. My name is Zia Tame. I am an advanced heart failure and transplant cardiologist here at the Cleveland Clinic. Today I will be discussing myocarditis and cardiac sarcoidosis. I do not have any financial disclosures or conflicts of interest pertaining to this topic. The diagnosis of myocarditis has been debated for many years, up until 1984. Along the ACC annual meeting in Dallas, Texas, a group of pathologists led by Dr. Eritz and colleagues formulated a working group to define myocarditis. The paper was subsequently published in 1987. In their paper, myocarditis was defined pathologically by the presence of inflammatory infiltrates with associated myocardial necrosis or damage that is not really characteristic of an ischemic insult. It should be noted that the Dallas criteria was built upon obtaining a tissue sample for histological review. As such, limitations included low biopsy yield, even in cases with diffuse myocarditis as the cause of death. More biopsies had more yield. Not to mention, different pathologists had different opinions about what constitutes adequate inflammatory infiltrates. Thus, in 1995, the WHO and the International Society and Federation of Cardiology formulated a task force to better define myocarditis and inflammatory cardiomyopathy. It included immunological and immunohistochemical criteria as noted below. This enabled more consistent diagnosis, and the clinical information was added to the definition of cardiomyopathy as having a dysfunctional myocardium. One of the major challenges of myocarditis is in its heterogeneity. It has many etiologies of infectious and non-infectious origins. With the current COVID pandemic, COVID myocarditis has been under the spotlight as a major cause of death in patients infected with COVID the past year. We will talk in more detail shortly. Other infectious causes include enterovirus, Coxsackie virus, Mycobacterium, Histoplasma cruzi or Chagas disease, among others. As far as the non-infectious etiologies, autoimmune disease would include sarcoidosis, giant cell myocarditis, lupus, rheumatoid arthritis, and systemic sclerosis. Hypersensitivity to medications and the ensuing eosinophilic myocarditis is a special subtype with especially poor outcomes. Given its vast heterogeneity, diagnosing myocarditis and its subtypes can be very challenging. It all starts with the background signs and symptoms, such as fever or malaise, joint pain, rash, exposure, among others. EKG changes or arrhythmias can be very helpful. What revolutionized our diagnostic abilities are the various advanced imaging modalities, such as cardiac MRI, cardiac PET, and advanced echocardiography. Each myocarditis subtype can present differently on imaging. For instance, this image represents a fused imaging taken by cardiac MRI and cardiac PET FDG18 scans. Notice the presence of patchy late gadolinium enhancement on cardiac MRI, indicative of inflammation and fibrosis. Superimposed on cardiac PET, those same areas where hypermetabolic activity does indicate the presence of active inflammation. This pattern is classical for cardiac sarcoidosis. Along with the right history, the diagnosis of sarcoidosis can be made without a direct tissue sampling and application of the Dallas criteria. This brings us to the big question: when should we obtain a myocardial sample? As you know, endomyocardial biopsy is most commonly obtained via a blind approach from the right ventricular side. Left ventricular biopsy could be safely obtained as well. Medical guidelines currently recommend obtaining endomyocardial biopsy in cases of unclear acute myocarditis, especially in the presence of hemodynamic compromise arrhythmias, or high-grade AV block. This is with the notion that the endomyocardial biopsy would enable us to diagnose confirm a myocarditis subtype that can be specifically addressed. Endomyocardial biopsy is generally safe, and we strongly advocate obtaining that whenever it is felt to change the diagnosis or the treatment. In fact, several reports has been published to date addressing ways to improve upon endomyocardial biopsy yield. In one series published by Liang et al., using voltage maps as a guide for bioptone did improve sampling to a specificity of 100% and sensitivity of 70%. In another series, biopsy analysis led to an alternative diagnosis in up to 39%. Due to the heterogeneity in diagnosis and the various myocarditis subtypes, treatment has been an issue for debate for many, many years. It makes common sense of altering inflammation if present. However, other than in cases of autoimmune disease, such as sarcoidosis, anti-inflammatory agents have failed to improve outcomes, especially in cases of viral myocarditis. Small studies did support the use of IVIG in the pediatric viral myocarditis population. Other than that, hemodynamic support with inotropic agents and mechanical circulatory support when needed remain critical. Unfortunately, we have encountered that firsthand the past year with the spread of COVID infection. The COVID pandemic has altered our lives in many, many ways. The presence of myocardial injury is very common in patients with COVID infection. Nonetheless, reaching a hyperinflammatory state with cytokinic surge can culminate in fulminant myocarditis needing ECMO support. Our institution reported one of the first cases of ECMO use in COVID myocarditis. Naturally, attempting to not only treat the virus with antiviral agents, but to suppress the ensuing inflammation makes a lot of sense. Unfortunately, this strategy has not been successful previously. The 3C study sponsored by the Cleveland Clinic and spearheaded by our colleague Dr. Kramer et al. Has failed in the preliminary analysis to show a benefit of suppressing inflammation with canakinumab in patients with COVID myocarditis. We will look forward to the final analysis. Shifting gears to another important subtype of myocarditis is cardiac sarcoidosis. Sarcoidosis is the formation of non-caseating granulomas that are inflammatory and arrhythmogenic. It represents a maladaptive CD4 and CD8 T-cell interaction to external stimuli in the genetically susceptible individual. It most commonly affects the lungs, but can affect the heart in 25% of cases, 5% of which is clinically apparent. Why is it so important? It has been considered for the most part as an uncommon disease. But most recently, we have noticed that up to 35% of patients, especially young ones, presenting with high-grade AV block or VT, did indeed have cardiac sarcoidosis. Not to mention that non-caseating granulomas are being detected in around 30% of cases on the core LV sample taken out during LVAD implantation, and up to 3% of explanted hearts after transplantation. Thus, it is more prevalent than we think. As such, understanding its progression and signs and symptoms would be important. Classically, once inflammation starts, it would not cool off. Inflammation eventually would be replaced by fibrosis. It remains unclear whether inflammation does spread, but the severity of presentation is dictated by the location and extent of inflammation and the more permanent fibrosis. Basal inferior segment involvement is very classical and can cause AV block and syncope and arrhythmias. Heavy ventricular involvement can cause diastolic and systolic heart failure. Cardiac arrest is a more common presentation as well. Bearing that in mind, more advanced imaging techniques were developed to assess the location and extent of the lesions. Cardiac MRI would assess for LG uptake, indicative of inflammation and scarring, and T1, T2 mapping, indicative of scarring and edema, respectively. Cardiac PET, although is less specific, would assess for active inflammation. It is predicated on a good dietary preparation and is not readily available in the country, unfortunately. Thus, we have been seeing more cases presenting to us for heart transplant evaluation that have reached the burnt-out stage that could have been avoided with proper immunosuppressive therapy early on. With the patchy nature of the disease involvement, traditional blind endomyocardial biopsies has a yield of less than 10%. Thus, societies across the globe have developed criteria to support cardiac sarcoidosis diagnosis based on the presence of associated signs and symptoms, starting with the Japanese criteria, the Rhythm Society criteria, and WASUG criteria. All demand high index of suspicion, preferably with the presence of extracardiac tissue or cardiac tissue diagnosis, and a combination of suggestive signs such as ventricular tachycardia, high-grade AV block, or treatment-responsive low left ventricular ejection fraction. Diagnosis and treatment is truly associated with very good prognosis, especially in the absence of low LVEF or heart failure. High-degree AV block can be reversible, but is associated with worsened outcomes. Fortunately, cardiac sarcoidosis is steroid responsive in most cases. Although no multicenter large clinical trials have addressed this question, pooled evidence does suggest the benefit of steroids in improving morbidity and mortality in such patients, including reversing heart block, heart failure, and ventricular tachycardia. At our sarcoidosis center at the Cleveland Clinic, our approach focuses on early steroids and a second agent use, such as methotrexate. We believe that early immunosuppression on the front end would alter the disease trajectory at the back end in a step-down rather than step-up immunosuppressive approach. Follow-up with serial imaging is paramount to assess for recovery. Electrophysiological studies and ventricular tachycardia ablation can be instituted successfully in selected cases. The use of dual-chamber ICD is important for secondary prevention and primary prevention in certain cases. Prognosis remains good, as I mentioned, as long as the LVEF remains preserved without heart failure. Once cardiomyopathy becomes advanced, implementing advanced heart failure therapies such as left ventricular assist devices or heart transplantation can be instituted with good outcomes. Finally, for the future, better diagnostic techniques need to be implemented, including more advanced endomyocardial biopsy methods and genomic sequencing. Thank you very much.